In this first episode, Josef Andersen, a Mulligan Concept teacher from Denmark, will interview Kiran Saptute, who is one of the authors of the paper Long-Term Efficacy of Mobilization with Movement on Pain and Functional Status in Patients with Knee Osteoarthritis, a randomized clinical trial. If you have missed the infographic and the video summary of this paper, you can find it on our social media channels, as well as on our website, www.mulligan.com. Kiran Saptute is the head of the Department of Musculoskeletal Physiotherapy at the SMT. Kashibai Novale College of Physiotherapy, in Pune, India, as well as an internationally accredited Mulligan Concept teacher. We hope you enjoy this interview and this project. We aim to actively contribute for bridging the gap between research-based knowledge and clinical practice.
Hello, Kiran. It has been a long time. I think last time I saw you, it was 2017 in Copenhagen. How have you been doing?
Hi, Joseph. Since then, I'm doing really good. I think I've cleared my CTA in 2017, and that's how I met you there. Nice to meet you.
Nice to see you again.
Yeah, nice to see you again.
This interview is about the latest study you have done with the osteoarthritis. Yeah?
Yes.
Can you please introduce yourself to the listeners, just to start with?
Thank you, Joseph. Hi, my name is Kiran Saptute. I'm an associate professor in musculoskeletal physiotherapy at Physiotherapy College in Pune, India. I have been teaching physiotherapy for past 12 years and in clinical practice since last 20 years. I'm an accredited Mulligan Concept teacher, achieving this milestone in my career in 2017 at Denmark at Copenhagen Conference. I'm passionate about evidence-based physiotherapy, including manual therapy, which drove me to undertake my PhD topic of which is evaluating effectiveness of Mulligan manual therapy for headache patients. My research interests are based on trying to understand more about manual therapy. So far, I have published a number of studies on evaluating management of shoulder conditions, knee disorders, ankle sprain, and lumbar radiculopathy.
Yes, it has been very difficult to keep up with your publication and work, and fantastic that you are going forward to do your PhD in the Mulligan Concept. Let's move on to the study of interest here. Could you please give us a short description of what you did and what you found?
In this RCT, we looked at evaluating long-term effectiveness of MWM intervention in a sample of 40 people with mild to moderate symptomatic knee osteoarthritis. MWM, in addition to exercise therapy and moist heat, was tested against exercise and moist heat alone. We chose a broad set of outcome measures for pain, mobility, and function. Function was assessed with the WOMAC scale, timed up and go test, and 12-step test. We wanted to identify whether the addition of MWM was of any benefit. 3 sets of 6 to 8 repetitions were performed, and the exercises were given to both groups were mainly strengthening for lower extremity that are recommended for patients with knee osteoarthritis. We treated patients for 3 times per week for 2 weeks. Our goal was to provide the intervention which will restore functional independence. At the same time, it should be easily manageable in our clinic. At long-term follow-up, the results were in favor of MWM to exercise therapy for all evaluated outcomes. The results were also clinically significant, and interestingly, the MWM was not superior over exercise for timed up and go test and 12-step test immediately post-intervention, but it turned out to be superior at long-term follow-up.
Kiran, in any study, any RCT or any study, there would be some weaknesses and strength points of any study. Did you identify any specific weaknesses or strength points to point out to the listeners here?
Yes, Joseph, yes, I agree with you. In any study, there will be strengths and weaknesses. This study is concerned, the exercise program provided to all patients was as per evidence-based guidelines. We followed subject for 6 months, which is important in evaluating the effects of any treatment, especially manual therapy. Further strength was that we followed the guidelines set out by an experts in use of MWM. A weakness is that this is A versus A plus B study design, thus can be criticized in some ways. Perhaps the additional attention provided to the MWM group was helpful. It would have been good to include a third placebo group as a control for contextual effect of manual therapy. This is a difficult and time-consuming to conduct such large study. However, in line with evidence-based guidelines for conservative management of knee osteoarthritis, exercise is a primary intervention. We do all agree. Thus, avoiding exercises would have been ethically challenged and also stressed by our ethical committee. Moreover, in clinical scenario, manual therapy intervention should never be delivered in isolation. They are always added on top of exercise therapy, and these indicate the pragmatic nature of our study design.
So you are considering maybe in the future to look at different types of design, are you?
Yes.
As a Mulligan Concept teacher, doing a study on the Mulligan Concept, obviously, there must be some considerations of bias in this way. Which steps did you take during the study to minimize that?
Yes, Joseph, this is a very important question to address. The risk of bias is difficult to eliminate in manual therapy studies. It is not like a drug trial. However, to manage this, we published our study protocol at Clinical Trial Registry before we started our study. The assessor was also blinded, which reduced bias to some extent. Bias was also reduced with concealed allocation. More importantly, we believe it is important that well-trained clinician should deliver the intervention, as this is likely to be more effective than compared to a novice or untrained clinicians. This will be applicable even to exercise therapy. Any intervention will be associated with the contextual effects, and we believe a well-trained clinician can handle contextual effects associated with intervention in better way.
Okay, so you focus more on the experience of the clinician was more important than trying to cover the bias possibilities. Yeah?
Yes.
Basically, yeah, and it's truly difficult if you are a clinician and associated with the MCTA at the same time. It will be very difficult to minimize the bias. You can do the best you can, and that's what it is. Yes, good. Kiran, during this study, you must have observed some different aspects that could be interesting to look at in the future, in future research. Can you tell me and the listeners if there has been some of these discoveries or interesting points during the study?
Yes, Joseph, future studies should replicate this research ideally with larger sample size, as well as adding additional of group receiving a sham or no active manual therapy intervention. This will enable us to understand the true effects of MWM. Future studies may evaluate minimum dosage required to treat knee osteoarthritis patients, optimizing cost effectiveness. Do we need 6 sessions or just 2, for example? As we know, Mulligan concept is very easily applied as a self-treatment at home exercises. So, could MWM be self-driven? Would this be as effective as the therapist provided MWM? I think future studies might also want to look at psychological variables. This might explain the mechanism effect of MWM.
Oh, very interesting, Kiran. So you're looking at having a bigger study, larger sample, adding a placebo component, looking at the dosage, how many mobilizations or exercise, looking also at the psychological factors that may play a huge role. We all agree, I think, in the Mulligan concept that psychological factors play a major role. Basically, we are doing something with the patient, they are doing the home exercises, they are active ingredients in the therapy itself. So that sounds very interesting. That's good for people who are looking to do some studies, but they may use this as a key point. Yes. Systematic reviews into manual therapy tend to put Mulligan in the same basket as everything else. So we're saying manual therapy, that could be all the names you can name within manual therapy, including Mulligan. How useful is that? Because in my point of view, Mulligan is completely different than most of the manual therapies we have. How useful is it to lump all the manual therapies together in research? Do you find that useful, or what's your view on that?
No, I don't think it is appropriate to lump all manual therapies into the same basket. There is a wide variety of techniques, dosage, duration, progressions, and rationale for its use. These are always lumped together, which does not allow discrimination between techniques, and also it cannot guide clinicians. MWM must be seen as a different to passive practitioner applied manual therapy, which is best on test, treat, retest model of application. The immediate change in symptoms during the MWM application separates MWM from other forms of passive manual therapy approaches. This is what my thought on behind is.
Okay, and it's the basic approach is very much an active approach. Many people think Mulligan is a passive manual therapy approach. It's everything but passive, because you cannot do it if you don't have communication with the patient throughout the test, treatment, and reassessment. And the patient has to be active all the time, from the beginning to the end. So you can do it passively. It's not a passive technique. So we agree on that. So that's why I find difficulties in understanding why they lump these things together and judge it as so. It's not a proper thing. We agree on that. Okay. Kiran, how important is self-mobilization for knee osteoarthritis? And could you see a future into doing some research in this area? So not the mobilization itself, the self-mobilization. How much value do you see there? And do you think we can do some research on that in the future?
As I mentioned earlier, self-MWM is an aspect of MWM that requires further research. It can be considered as a way to empower patients, encourage them to be in charge of their own well-being and function, and also to get more involved in exercise program. It would be a great topic for research. Does self-MWM provide greater benefits than other forms of exercise? Does self-MWM impact on a psychological variables? There is a great deal more research that we need to do on this.
That sounds good, Kiran. It will keep you and other researchers very busy for many years to come. And it's important to find out, of course, these are very important questions that we still need to understand and discover, because we give home exercise all the time. We don't know the value of it in relation to the treatment or in relation to other factors like psychological factors, empowerment and all that. It would be nice to look at these factors and see how they play into patient rehab. But that's very, very interesting point for sure. Kiran, guidelines recommend usually a multimodal approach for knee osteoarthritis, like losing weight, exercise, education, activity, and sometimes manual therapy. Manual therapy is not the biggest thing in osteoarthritis, but this study is about manual therapy. How do you decide to whom would you apply mobilizations with movement, for example, or other therapy, but we are into the Mulligan concept here. So how do you decide? This can be interesting for the clinicians to know.
That's a very interesting question, Joseph. Specifically, if we talk for MW, a recent Delphi study looked at that question. It's not clear that experts agree when to use MW. Clearly, it would be better to use the technique only on a people who have substantial improvement in pain and range of motion following trial application of MW. Bearing in mind what we have discussed earlier, that we don't stop if first application of device has no effect. We may need to find out the another direction which may provide some substantial effect. We need to explore other potential techniques. We also need to consider the patient's belief, yellow flags, possibility of centrally mediated mechanisms, and so on.
That's fine. So I gather from it, you should try it, and if it works, as we do with the pill concept, if you can do a mobilization that makes your movement better and pain-free or with less pain, then that justifies to try it for a few sessions or so. Is it? That?
Yes.
Kiran, one thing one noticed when you read your study is that your group did not get any funding to do this study. And this is a half-year follow-up study. If we know about studies, they're quite costly in general. How did you manage to do a study like this with no funding? Basically, is it you paid from your own pockets, or what did you do?
No. We don't pay from our own pocket. I agree with you, Joseph. Such studies require fundings. Good amount of funding needs to be invested in these studies. Unfortunately, funding is not available for studies like ours. This study is a part of postgraduate program at our university. The infrastructure is all provided by our institution, and we do a lot of manual involvement is there in these studies, which the work will be distributed amongst all the faculty members.
Oh, that sounds fantastic, Kiran. So you basically invested a lot of time and efforts, and the university supported with giving you venues and facilities, whatever you needed for the study. Wow, that's a lot of work but the results are interesting.
Thank you, Joseph.
Thank you, Kiran. Thank you very much for joining this program and sharing your ideas of your research with us. I think many listeners will find that very interesting, and we will look forward to read more of your work and support you, of course, into doing more research. Thank you very much. And we thank the listeners as well who has been listening. Thank you, Kiran.
Thank you, Joseph. Thank you very much.
And see you soon.
See you soon. Yeah.
Good. Thank you.